is Indian Country Today.
Welcome, and thank you for joining us. I'm Mark Trahant. These are the news headlines for Monday, June 29th. A federal judge has ruled that Alaska Native corporations will receive a share of the $8 billion under the Coronavirus Aid, Relief, and Economic Security Act, CARES Act. Some 20 tribes sued, saying that Alaska Native corporations are not tribes and therefore should not receive the funding. U.S. District Judge Amit Mehta said Alaska Native corporations do qualify because of the structure, the history, and the boards of directors as tribes for purposes of the CARES Act. The decision means that U.S. Treasury Secretary Steve Mnuchin will begin distributing at least $162.3 million to the Alaska Native corporations. Alaska Federation of Natives President Julie Kitka said she was pleased with the decision. Alaska has a unique history of tribal self-government and native self-determination, she said. The national debate continues about mascots and symbols. President Donald Trump signed an executive order last week to use federal law enforcement to protect statues. 4 men have since been cited with felony charges for trying to remove an Andrew Jackson monument near the White House. These are the first federal charges related to the destruction of statues and monuments. Across the country, both protesters and elected officials are taking a second look at symbols in the public space. Legislators in Mississippi voted Sunday to remove the Confederate flag from that state's flag. Leaders from business, religion, education, and sports all came together and spoke forcefully against the 126-year-old banner. There was a call for a new flag, one that better reflects the diversity of a state that is nearly 40% African American. It was the last state flag to carry the Confederate symbol. And in Orange County, California, Democratic Party leaders have called for the removal of John Wayne's name and statue from the airport. John Wayne was the iconic cowboy and Indian killer in the movies, but in real life, he made no apology for his racism. He told Playboy magazine in 1971 he was for white supremacy, and it was a good thing that this country was taken from the Indians because they were being selfish when people needed land. In a related story, there is growing pressure on the Washington NFL team to change its name. The team has already removed a statue of its founder, George Preston Marshall. He was the last owner to desegregate an NFL team and only did so in 1962 under great pressure. Virtually every national Indian organization has called for the name change. As a joint letter to Washington owner Dan Snyder said, we need to remember that the franchise name is not just a word, it's a symbol that loudly and clearly signals that Native Americans are not worthy of respect. Last week, a coalition of 90 investors representing $620 billion in assets sent letters to 3 NFL sponsors, Nike, FedEx, and Pepsi. The investors said it's time to terminate the business relationship with the NFL team until it changes its racist team name. Indian Country Today has been tracking COVID-19 cases and deaths in Indian Country for the past 3 months. We turn now to ICT's Washington editor, Jordan Bennett-Begay, for the latest update. Hello, Jordan.
Mark. We have COVID-19 updates from 6 tribes over the weekend, and here's a look at the latest numbers from our database. There are 11,700 positive cases and 478 deaths in the Indian health system. Again, that's a total of 11,700 positive cases and 478 deaths as of June 29th. The Mississippi Band of Choctaw Indians in Mississippi saw a rise of 25 cases since we last reported. The tribe has a total of 906 cases and 63 deaths. In North Dakota, the Mandan, Hidatsa, and Arikara Nation reported 1 more case, making it 42 cases in total for the tribe. And in Arizona, the White Mountain Apache tribe announced 77 new cases. They have a total of 1,696 cases and 21 deaths. And for the Navajo Nation, they announced over the weekend 191 new cases and 15 more deaths. The nation ended its second week in lockdown after taking a pause for 2 weekends. And Mark, these are the cases only reported, and the CDC said last week that for every case recorded, there are an additional 10 infections, and cases continue to grow worldwide.
Thank you, Jordan. We'll be right back. This is Indian Country Today.
This is Indian Country Today.
Welcome back. The Indian Health Service is one of the most complicated agencies in the federal government. In addition to operating a healthcare network of clinics and hospitals, the agency is also a major funding source for tribal and urban facilities across the country. Now, of course, the agency is taking the lead in managing the most significant health crisis in our lifetime, the coronavirus pandemic. Today, we visit with Rear Admiral Michael Uyaki, the director of the Indian Health Service. He's in Phoenix to visit the medical center there. Admiral Uyaki, let's start with an overview. Just walk us through what happens on a day-to-day basis with COVID-19 response.
Great, thank you, Mark, and good morning, everyone. For the Indian Health Service, we've been engaged now for just over 3 months in responding through incident command posture to the coronavirus. This means that we've stood up a special structure, and we have our teams meeting at least once a day, many times, multiple times a day. We've stood up in each of our hospitals and health centers, incident command teams. So they meet every morning to huddle and plan out the day to really focus on those areas that need to be addressed. But overall, the approach has been to prevent, detect, treat, and to recover from the pandemic. So each of the teams is focused on those 4 areas, and that makes up their daily routine. So you would imagine over 3 months now that wears on you. It becomes very difficult. We start to have people fatigue. So it is quite the undertaking.
This is one of those things that you've trained for years. Now that we're into it for 3 months, what's been the most surprising part of the story?
Yeah, well, hindsight's always 20/20, but I don't think that the country really understood in a true pandemic the level of need for personal protective equipment and testing capacity. We've had pandemic plans on the shelf and have exercised according to those plans to ready ourselves. But until you're really in the thick of it and you see the entire country dealing with the same situation at the same time, that was really eye-opening, I think, for everybody.
Where do we stand now on PPE and other supply chain issues?
Well, thankfully, for the most part, we're in a much better place than we were just a month or 2 ago. We've had manufacturing really ramp up, both domestically and internationally. But we still do have some needs out there. Most recently, we've been in need of gowns, Tyvek gowns and other protective gowns. Many of the manufacturers who were making gowns previously switched over to making masks because that was the big need. And then we found that those who had been making gowns, now we didn't have enough gowns to go around. So they're making those adjustments on the manufacturing side. And I think for the most part, we've been able to find the majority of what we've needed lately.
I know you get out and tour Indian country a lot, and like myself, I've just been amazed at the way folks are stepping up with their own making of masks and other equipment. Not as much for the medical side, but even in some cases for that.
Yeah. Now, I would love to be able to wear my ASU designed mask in my uniform, but it's not regulation. So.
One of the things that I think would surprise a lot of people is the tribal and Indian Health Service response to the pandemic. And in some ways, you're ahead of the rest of the country in how you're managing this crisis.
Well, we've been the fortunate recipients, and I think the Department of Health and Human Services, Congress, and the White House have really seen the need in Indian country, and we've benefited from that identification. I think one of the areas that we like to talk about a lot is our testing rates. That we've really done a great job in many parts of Indian country. I would say some of our tribal nations have the highest testing rates in the world. They've been able to, in Navajo Nation, test almost a quarter of their entire population. So that's something that we should all be proud of, is that we've been able to build that capacity and ensure that our patients are being tested.
And I know you've told Congress that there's no good way to measure death rates, But even if you look at death rates based on demographics, we seem to be doing pretty well in Indian country.
For the most part, but we are very cautious on death rates, just knowing about, the racial misclassification on death certificates for American Indian, Alaska Natives. That is something that we've been working with the Centers for Disease Control and Prevention on for quite some time to try and get our arms around. But optimistic that the low death count is a good sign for us.
What other issues with CDC have come up in this episode?
Yeah, well, we've definitely been working closely with CDC on contact tracing and water issues. We've actually had some CDC professionals come out and work with our engineers and sanitarian folks on access to water, clean water. But for the most part, contact tracing and epidemiological support have been the two areas that we've worked most closely with the CDC.
What's the work with, I mean, one of the things people know is that Indian Health Service is the largest employer in Indian country. And with contact tracing growing as a field, what are kind of the ways that's looking at in terms of creating jobs in Indian country?
Yes, well, definitely. We've historically in our system relied heavily on our community health representatives and our public health nurses, but this job far outstrips our capacity. The Association for State and Territorial Health Organizations identifies a benchmark of about one contact tracer for every 1,000 patients served. So that number in Indian country would be quite high with 1.6 million patients being served. So we've had to look out to additional staff members. The best contact tracers are from the communities being served. So that bodes very well for trying to identify and then train those individuals up. We need a lot of them.
Where are you most concerned about right now?
Well, for sure, in those hot spots around Indian country, I think everyone's well aware of Navajo Nation being a hot spot. We work very hard and very closely with the tribes to identify, who's comfortable being identified publicly as a hot spot and who's not. So we wait until tribal leadership goes out and shares their numbers first. But through that mechanism, we know that there are hotspots at Mississippi Band of Choctaw Indians down in Mississippi, White Mountain Apache. We've had the Quechan and the Cocopah, the Hualapai here in Arizona, several tribes throughout the country. So those areas that are identified as hotspots who have more cases that need to be followed will need the greater manpower.
It's interesting because some tribes have been so aggressive and successful. And when you're successful in keeping down either infection rates or death rates, there's pressure to say, open up, do everything. And how do you balance that?
Yeah, I think that's really the struggle for the entire nation now. We're trying to balance this economics versus health, but there's also a very important balance of behavioral and mental health versus physical health that needs to be taken into account. And I think really we need to go back to our initial prevention discussion, social and physical distancing, frequent hand washing for at least 20 seconds, wearing a cloth face cover in public. There are things that we can do and still ramp up and move a little closer to normal. But I do think it'll be quite some time before we get to our true pre-pandemic normal.
Speaking of normal, I want to ask first about the other health issues during this whole crisis. If you're scheduled for routine services, you're probably not going to get there right away. How does that impact people's health going forward?
Yeah, well, unfortunately, in Indian country, as most of you know, we have had high disparity rates in diabetes, upper respiratory infections, heart disease, even before the pandemic hit. And so ensuring that services continue in some way for those individuals through innovative mechanisms like telehealth, or even by making telephone calls to ensure that individuals are getting their medications and the treatment that they need. Many of our sites have provided prescription delivery services, or they've had drive-up delivery of prescriptions. Just ways to maintain that physical distancing, but still getting the services to the individuals served. Telehealth has really, I think, been the sea change. We've seen a 12-time increase in the use of telehealth in the Indian health system of care alone, which we're very hopeful that we'll be able to retain even beyond the pandemic.
And I know you don't probably hear people talk about one of the advantages of the Indian health system very often, but one of the advantages of the Indian health system is that it is a system that you can see kind of the whole approach to things. What can the U.S. learn from that?
Yeah, well, I think being a federally operated healthcare system, we get compared often to a socialized system like they have in Canada or they have in England. And what are the goods and the bads? And there are both. I mean, we're very much dependent on federal appropriations, but we're also equally dependent now on third-party revenues, Medicare, Medicaid, private insurance. But we do have the benefits of being able to really focus on the population's health as a priority. And we now have multiple generations of families' health data in our electronic health record, which we can learn from and improve over time. And I think that we've really seen the benefit of that in the area of diabetes care and treatment, where for the first time ever, we've seen a slight decrease in adult prevalence of diabetes in American Indians and Alaska Natives, which has never happened, and it's not happened in any other race or ethnic group to this point.
Do you worry that progress will be stalled during the pandemic?
I do have concerns. I mean, we're being innovative and we're doing everything we can to ensure that treatment continues, but there are some things outside of your control, and we are worried about the effects of the social isolation on mental health status and whether people turn to other coping mechanisms as a result.
Admiral, what's been the economic impact of the Indian health system from all of this?
That has been the huge question mark at this point. We have some anecdotal data because all the data that we have in our system is based on our federal operations, and then we have many tribal and urban programs who voluntarily provide their data to us as well. So that we've been using that as a flag to what's happening overall in Indian country. And we've seen between 30% to 80% reductions in the third-party collections at sites, depending on where they're at geographically or the type of facility that they're operating. We've made up for that gap through some of the congressional appropriations, the waves of funding that have been provided. Provider relief funding is a good example, which one of the primary purposes was to make up for that lost third-party revenue. But I do feel strongly that it's going to take several years to make up for these lost third-party revenues that we're experiencing currently.
What happens in the meantime, I guess, especially for your tribal partners that can't tap Medicaid or some of the other funding sources?
Yeah, well, they're forced to rely on reserves that they may have had or pull from other sources. Gaming revenue is always looked to as a resource, but as we all know in Indian country, not everybody has a large reserve of funds built up. Many of those casinos are just providing jobs and breaking even. So it's very few of those large tribes that have huge reserves that they can rely upon.
How much planning is going on for the transition, for the economic transition for the next few years?
Well, I think that there is quite a bit of discussion at the White House level. We have now stood back up the White House Council on Native American Affairs. And one of their first focus areas as they bring tribal leaders together will be on energy consumption, energy use, looking at those tribes that have oil and gas and other reserves that they can focus on. But when it comes to casinos and gaming, I know that the National Indian Gaming Commission has been working closely with tribal leaders to stand their casinos back up in a safe way, both for their employees and for the consumers of those facilities. And working hard to do it, but to do it in a safe way.
One of the challenges of IHS and the Indian health system in general is recruitment and retention. How has that fared during this pandemic?
Yeah, thankfully, we've had, through the Office of Personnel Management, the ability to pay hazard pay during this time. So that has enabled us to increase pay by up to 25% of their regular base. And it's proven to be a pretty good retention tool. So we've historically been operating with a 20% vacancy rate across all professions, even higher in some of our physician, nurse, physician assistant positions, up to 30%. But for the most part, we've been holding steady, steady with bad vacancy rates to start with.
Would that include some of the other professions, such as dentists and some of the other areas that?
You speak of dentists and optometrists, a couple of the provider types that haven't been practicing now for 3 months, other than emergency dental needs. So we've actually repurposed a lot of our dentists. A lot of our dentists are leading the incident command teams or providing other services that benefit our Indian health system of care. Just waiting for us to be able to ramp back up those other provider types. But for the most part, I think our numbers have held. We have seen over the last several years slowly decreasing rates of employment for physicians and dentists in our system. We've been losing physicians slowly and turning more to contract providers.
You think there'll be more of that then going forward?
I hope not. We are really trying to build up the training capacity through graduate medical education, residency rotations. HRSA and the VA have both put funding together with Congress's support to increase the number of residency programs in Indian country. And we're hoping that enables us to develop a new pipeline of providers.
In 1918, after the flu pandemic, the whole first wave of Native American nurses came from that experience. They wanted to do something and went into school to do that. Is that same sort of narrative possible in this generation, not just for nursing, but across the board?
Yeah, I sure hope so. I always like to look for that silver lining and that positive next best thing that could be coming our way. And I would love to see a renewed interest in healthcare within our Native communities. We could really use those nurses and respiratory therapists and nursing assistants, you name it.
In fact, the whole Ganado nursing school was created out of the pandemic. And it became the first nursing school for Native American women, basically because of what people saw on the ground.
Well, we could sure use them for sure.
So as we conclude here, I guess let me shift to a public health focus to the end. What's the constant reminder for people right now during this, whether they're impatient or not? What do they need to be doing?
Yeah, I think we all need to continue wearing our cloth masks. Keep them handy, use them, continue social distancing. If you feel ill, call your provider in advance before you go into the hospital and get your provider's advisement on what you should do. We really need to do all we can to protect our elders at home, and we're seeing now that the demographics are changing slightly, that we're starting to see more young people getting sick. And I think that part of that is a result of not adhering to some of the public health orders that have been put in place. We really do need to continue to practice these as long as we can to hopefully keep that new cases flattening off. Thank you, Mark. Thanks for having me. Good to see you.
That's another edition of Indian Country Today. Thank you for joining us. I'm Mark Trahant.
This is Indian Country Today.